So we'll go into the next discussion, which is going to be um, again one of the common things you get to see in your ward. Okay, lot of times what happens, you admit a patient, okay, and the patient will worsen, okay, and when the patient worsens, you are going to intubate the patient, okay. Once you are intubating the patient, what is going to happen is the patient after few days he will develop worsening, okay. So you will think, I intubated the patient and I felt patient is uh, improving, okay, but why the patient is worsening? What is the reason for this worsening? So whenever you have a patient like this and your thought goes like this, then you have to think about very important thing, which is going to be ventilator associated pneumonia, okay, ventilator associated pneumonia. So whenever you have a patient where you are suspecting ventilator associated pneumonia, you have certain risk factors, okay, risk factors, and these risk factors are going to be very important to make uh, a thought process in such a way that patient is going to have this kind of ventilator pneumonia. I have to go in this direction. For that, we have certain risk factors. Okay. So, what are the risk factors? So, whenever you have a patient, okay, coming to you with intubation followed by worsening, okay, then the risk factor will be more in patients who are elderly, more than 70 years of age. Okay, 70 years of age. Okay, whenever he is having pre-existing chronic lung disease, okay, he has a poor GCS, okay, and poor GCS aspiration, okay, then patient on PPI or H2 blockers, okay, patient on broad spectrum antibiotics, broad spectrum antibiotics, okay, whenever a patient is on prolonged intubation, then these patients are going to have high risk for VAP. Okay, high risk for VAP. Okay, so when you will suspect a patient is having VAP, okay, so you have these patients with risk factors, and these fellows have a chest X-ray, okay, chest X-ray, which is done twice, okay, done twice, and shows new infiltrates, consolidation, cavitation, new infiltrates, consolidation or cavitation, then there is high chances it's a VAP, okay. Then next is lab parameters, okay, lab parameters. The patient having a total count which is less than 4,000 or more than 12,000, more than 12,000. Next is clinical features, okay. Clinical features, the patient has temperature which is less than 36 degree or more than 38 degree, okay. Patient has increase in the secretions. On auscultation, new onset wheeze or crips, okay. Patient has signs of respiratory distress. So patient has something like he's telling that I mean, he is lying down, and the staff or the intern there is telling that patient is having increased respiratory effort, retractions of the chest, okay, there is going to be nasal flaring is there, okay, patient is in distress, okay, then the patient is having higher chances of getting high chances of going into VAP, okay. And patient SpO2 or PaO2 is worsening, okay, is worsening. So all these indicates that the patient is having VAP. Okay, so these are certain indicators for you for VAP. Okay, so this is going to be very important features which are going to tell you that patient is having VAP. Okay, now for this you have a scoring system called as clinical pulmonary infection score. It is called as CPIS score. So even though the scoring is not important for you, you have to know the components of the score. Okay, so the components of the score are flocked. Okay, so here we have fever. Okay, then leukocyte count. O for patient oxygenation in the form of PaO2 by FaO2. C for chest X-ray. T for tracheal secretions. Tracheal secretions present or not. Okay, and tracheal aspirate culture sensitivity. So these are the scoring systems. Okay, based on this, you are going to score the patient and uh, decide what kind of worsening patient is having. Okay, so this is called as a CPAS score or clinical pulmonary infection score. Okay, clinical pulmonary infection score. We are going to have fever, leukocyte count, oxygenation, PaO2 by FaO2, chest X-ray, tracheal secretions, and the secretions culture sensitivity. Okay, so these are taken into account. Okay, so how we are going to investigate the patient? Investigate the patient. Okay, so whenever you investigate the patient, I told you chest X-ray will show worsening of features. Okay, but that is not going to tell you what kind of infection he has. Okay, so what you're going to do is you're going to go for culture sensitivity. Okay, in this culture sensitivity, how you're going to do is you're going to take ET aspirate. Okay, you go for ET aspiration, you go for ball. Okay, and you go for protective specimen brush. Okay, so ET aspirators, you just put the suction tube, aspirate the ET secretions. Next is ball, bronchoalveolar lavage. Okay, you just rinse the ET tube uh, through a bronchoscope. Okay, and take the secretions. Or you can go for a protective specimen brush. This is a brush. This brush has bristles like this. You go inside the ET tube. Okay, you go and take a wipe. Okay, wipe. Okay, you just swirl around the tube and take the secretions and go for culture. Okay, and ET aspirate is significant whenever the colony growth is more than 10 power 5 per ml. Ball is significant whenever it is more than 10 power 4 per ml. Protective specimen brush more than 10 power 3 per ml. Okay, so this is very important. Okay, this is very important. And you collect the specimen, send the sample, check for the growth. Okay, check for the growth, and based on the growth you are going to go for treatment. Okay, based on the growth you are going to go for treatment. Okay, so this is very important thing you have to know. Okay, copy. Yes, so how we are going to treat a patient? Okay, so treatment of VAP. So again, it is going to be protocol based treatment. So here, so first is I'm going to check for any risk factor for resistant gram negative pathogen. Okay, so you see any gram negative pathogen, chances are there. Okay, okay. So whenever there is no risk factor for gram negative pathogen, okay, that is again it is going to be fitting true for all risk factors like previous antibiotics, previous hospitalization, local antibiogram, etc. Okay, so gram negative pathogen, no risk factor is there. Okay, then you go for piptas levo, or cefepime. Okay, so or okay. Then next is patient has gram negative pathogen risk factor present. Okay, then what you're going to do is in those patients, Piptas, cefepime, ceftazidime, imipenem, or meropenem. So all our pseudomonal drugs, okay, those things, okay. Along with this, you are going to add one more drug, which is going to be either fluoroquinolone or aminoglycoside, or you're going to go for colistin polymyxin. So colistin polymyxin, if you're going to give, means we have no other options after that, okay, after that. So this is how you have to select one from here, one from here. Okay, so this is how you're going to give treatment in patients with VAP. Okay, VAP. And if there is a risk factor for MRSA, then what you're going to do is you're going to go for linezolid or vanco. Okay, so this is how you go for treatment. But ultimately, the treatment is based on the local pathological and culture sensitivity features. Okay, the local antibiogram decides the treatment. Okay, actually, but this is the protocol. Okay, so whenever you have no risk factor for gram negative, then it is PCL. Okay, piptas, cefepime, levofloxacin. Okay, again, if it is going to be here, PCM. Okay, piptas, cefepime, miro, or imipenem. Okay, fluoroquinolone. This is Genta. Okay, or Tobra, or amikacin. Understood? So you have to see the local antibiogram. Okay, it differs from place to place. Okay, but guideline says that whenever you have no risk factors for gram negative pathogens, like patient is not having any kind of prior antibiotic therapy, prior hospitalization, those kind of risk factors is not there, then you go for piptas, levo, and cefepime. Okay, PCL. If it is going to be having risk factors, okay, risk factors for anything like hospitalization, okay, well, explain Bana what is there. No gram negative pathogen. Okay, whenever the patient has same thing, any hospitalization, any antibiotic therapy in the past, then it is going to be considered as patient has risk factor for gram negative organism. Whenever those risk factors is not there, okay, then you are going to consider the patient is having no risk factors. Okay, whenever there is no risk factors, you go for PCL. Okay, whenever risk factor is there, then what you're going to do is you are going to give one from this column. Okay, one from this column, one from this column. Okay, one from this column. Together, you add both the drugs. Whenever you have anything risk factors like antibiotic in the past, patient had hospitalization in the past. Okay, then you go for this regimen where it is going to be 1 plus 1. 1 plus 1. Understood? But ultimately, it depends upon the local antibiotic policy. Every hospital has their own antibiotic policy to follow. So, based on the local antibiogram, your treatment is decided, but you have to check for risk factors. Okay, antibiotics given in the past. Okay, hospital admission in the past. Okay, these risk factors are present. Okay, then you are going to go for combined treatment. Okay, So you should know in your hospital how the uh, antibiotic profile is being followed, or antibiogram of your hospital, culture sensitivity of your hospital, which is the most common resistant organism in your hospital, which is the most resistant drug in your hospital. So these are going to decide, okay, whether you're going to go for this group of drug or the other group of drug. Okay, other group of drug. On top of that, if you're going to be MRSA, then what you're going to do is you're going to add this one. Okay, this is how treatment is given. So how we are going to prevent VAP? Prevention of VAP. So you are going to always advise proper hand washing by the proper hand washing by your healthcare professionals. That is very, very important. Don't touch one patient and then touch another patient. You're going to transfer the infection. Then next is head and elevation. Head and elevation. Okay, that is second important thing. Okay, you keep the patient head and elevated 3 to 60 degree. One thing is prevent aspiration, and another thing is to prevent gastric acid aspiration. Okay, then avoid nasal ET tube. Okay, would have seen patients being put on UT tube through the mouth. Okay, there are instances where there is difficult intubation. There is something where you can put through the nose also. Okay, that is and high risk for VAP. Okay, then do routine subglottic aspiration. What is subglottic? Yeah, Pseudomonas is again gram negative, right? Yes or no? It depends. Again, it depends. Clinda again depends. Okay, it depends on the situation. Whenever you think MRSA is associated with anaerobic contamination, whenever aspiration is there, then you can go for clindamycin. In your exam, what they are going to ask is, how they are going to ask is, a patient came with a history of no previous hospitalization, and patient had no history of any kind of treatment before, with sudden onset of fever and followed by cough, and it was diagnosed as a viral pneumonia, followed by patient started desaturating and he was intubated. On day 3 of intubation, patient developed fever with purulent secretions in the ET tube. Which of the following will be the antibiotic of choice? Piptaz monotherapy, piptaz with aminoglycoside, cefepime with ceftazidime with meropenem, colistin polymyxin therapy. What will be your treatment? Yes. What will be a treatment? So you'll go for A, right? Patient has no past history, viral pneumonia followed by worsening. Patient is coming to hospital. So you have to see the profile of the patient. Okay, profile of the patient. So approach can be individualized approach. Okay, I'll be approaching the patient in a different way. Okay, and another one will be different way. Okay, if two professors are there in a department, they will not approach the patient the same way. Okay, it is individualized approach, but protocol is the one which should be giving an idea how to approach the patient. Okay, protocol is the one which is going to give you how to approach a patient, and always approach varies from people to people. Clinical approach varies from person to person. That you should be very sure of. Okay, now this is the ET tube. Okay, this ET tube has a cuff here. Cuff here. This is a cuff. Okay, now what happens in this patient? There is pooling of secretions. Pooling of secretions. pooling of secretions. Whenever there is a pooling of secretions like this, what is going to happen is you have to go for aspiration of it. I have to put a suction tube. Okay. Nowadays we have, yeah, very good. So nowadays we have tubes which are attached with another tube. Okay, where you can do aspiration. Okay, aspiration. This is very very important. See, this prevention is very very important. It is asked in exam. Okay, then avoid unnecessary PPIs. So nowadays the practice is for all patients, irrespective of admission, we put the patient on PPI. Okay, so we are going to make a world where there is going to be no acid in the stomach. Okay, so we are going to. So previously they say even if you put an iron piece into the stomach, the iron piece can be uh, uh, diluted by the acid. But okay, now we are going to a world where in future there will be transformation, genetic transformation. There will be no acid secretion in the stomach. Okay, directly we have to give food into the intestine. The day might come because the whole world, especially whole India, is in PPA. Okay, whole India is in PPA. Okay, so the evolution will be like that in future. Stomach will become a vestigial organ. Okay, so avoid unnecessary PPA. Okay, the problem with the PPA is the PPA will suppress acid secretion. Okay, but because patient is intubated, there is high chances of stress ulcer in these patients. So for that, what you can do, you can go for sucralfate, etc. But they are not so effective. Okay, even though they try to reduce VAP incidence, but what they do is they are going to cause stress ulceration, which is going to worsen. Okay, so that you have to be very very careful. And nowadays we have silver coated ET tube. Silver coated ET tube. Okay, what is silver coated ET tube? This ET tube is coated with silver. Okay, so these will constantly emit or release silver ions. Okay, these silver ions will go and bind with the bacteria. Okay, and destroy the bacteria. Any local proliferation is there. PPA. Okay, so what PPA does is, okay, so whenever you have decreased PPA, okay, what is going to happen? The food digestion is going to be prolonged. Okay, so whenever the food digestion is prolonged, what is going to happen is the food contents may enter into the esophagus. Okay, and from the esophagus it may enter into the ET tube. Okay, or whenever patient is lying down, again what is going to happen? Because there is a delayed gastric emptying, the food might slowly rise into the esophagus. Okay, for that reason. Okay, so silver coated ETA available. Okay, then start early enteral feeding. Start early enteral feeding. So these are few things which you have steps you have to take to prevent ventilator associated pneumonia. To prevent ventilator associated pneumonia, these are few steps which you have to take. Okay, to prevent ventilator associated pneumonia, and these steps might be life saving in the patient. Okay, life saving in the patient. So this is about your ventilator associated pneumonia, and ventilator associated pneumonia is a very very important thing you note in your patients. Okay, so you commonly get to see these kind of patients in your ICUs. Okay, so you should be very careful in dealing these patients. Okay, so with this we are finishing our pneumonia as such. Okay, next is we are going to have one important topic, okay, which we are going to see as short as possible, because when we took in 2021, we took this topic with greatest effort for 3 hours and 4 hours. Okay, but now we are going into such a way that we are not going to take too much of time here. We will just see the important aspects, exam point of view aspects. Okay, so now with the next topic, what we are going to see is going to be COVID pneumonia. COVID pneumonia. Okay, so COVID. Okay, the word which created lot of buzz and fuss Okay, so COVID-19. Okay, what is COVID-19? So this virus was identified as COVID in 2019. So it was named as COVID-19, and it is caused by a virus called SARS-CoV-2. Okay, SARS-CoV-2. Okay, this disease, okay, was actually a nightmare for everyone. Okay, and WHO recommended this disease as a public emergency in Jan 30, 2020. Okay, and it declared this disease as a pandemic in March 11, 2020. And you all know towards the end of March, we went into lockdown. Okay, we went to lockdown. Okay, first time we heard this word called lockdown. Okay, so how this disease spreads? Okay, this disease spreads from person to person. Person to person by droplet infection. Droplet infection. Okay, and which is generated through aerosols. It also spreads through body secretions, again because of the aerosols. Okay, and indirectly through fomites. Okay, it will get deposited somewhere, and when the person touches the face, again it is going to spread. Okay, so it is going to be major source of spread is going to be droplets, and it is also going to spread through fomites, which is going to be person getting contact with the contaminated surface. Okay, contaminated surface. Okay, so this is going to be one very important thing. Okay, what is the risk factor? Risk factor for COVID is going to be age of the patient more than 65 years, having chronic disease like hypertension and diabetes, COPD, renal failure. All these are risk factors. Okay, patient on dialysis. Okay, patient having any kind of immunocompromised status. Immunocompromised status. All these are going to remain as a risk factor. Okay, risk factor. So this is very important. Okay, how you are going to suspect a case? When you will suspect COVID. Okay, whenever you have any patient with severe acute respiratory tract infection, okay, where patient is going to come to you with fever, with cough or shortness of breath. So a patient is coming to you and he tells that, sir, I have fever with cough and shortness of breath, and I had a history of travel to a country. Previously it was told, but now even travel you can consider country with COVID-19 epidemic. Previously it was considered in those patients who traveled to any country where there was a COVID epidemic. But nowadays it is everywhere. So any travel, okay, then you have to consider COVID. And symptomatic patient with contact with a positive case in last 40 days. Last 14 days. So a patient who is symptomatic and he is in contact with the COVID patient recently, okay, then these patients you have to suspect COVID, and this is going to be becoming a confirmed case of COVID, okay, whenever lab diagnosis is positive. Lab diagnosis is positive. Okay, so a patient with coming with SARI, okay, history of travel to a country with COVID-19 epidemic, and he is in contact with a positive case in the last 14 days, is going to be considered a suspected case of COVID, and he becomes a confirmed case once the patient laboratory investigation is a confirmatory one. Okay, so what is this virus? Okay, what is this virus? This virus is a SARS-CoV-2 virus, as I told you already, which belongs to a order called severe acute respiratory infection. It belongs to an order called nidovirales. Nidovirales. Okay, belong to a family of virus called coronaviridae. Coronaviridae. Okay, in that they belong to a subfamily orthocoronaviridae. Okay, and if you want to go for the genera, if you want to know the genera is beta coronavirus. Okay, in microbiology, it was asked nidovirals. Nidovirals was asked in microbiology. Okay, so it belongs to order nidovirales, family coronaviridae, subfamily orthocoronaviridae, and genera beta coronavirus. Okay, what is the structure of this virus? Okay, what is the structure of this virus? Okay, so this virus is a spherical virus. It is a spherical virus. Okay, it is a spherical virus. Okay, and this virus has a surface protein. Okay, surface protein. Okay, and this surface protein is going to be one important thing. Okay, which will help in infection transmission. Okay, so it is going to have like this. Okay, here what we are going to have is we are going to have a protein which is going to lie down like this. Okay, and this is called as spike protein. Okay, and here we have a protein called membrane protein. Okay, then we have envelope. We have envelope. Okay, and inside we are going to have a star-shaped structure. Okay, and the star-shaped structure is going to have star-shaped structure, which is going to contain genomic RNA. Genomic RNA. Okay, and here we have nucleocapsid. Nucleocapsid. Okay, so it is going to have lot of spikes like this. Lot of spikes like this. Okay, the same time you're going to have like this. Okay, so this is a structure of the virus. Okay, so it is going to have spike protein, membrane protein, envelope protein, and nucleocapsid. Okay, and inside it is going to have is genomic protein. Okay, so it is going to have structural proteins called smart men. Okay, spike, membrane, envelope, and nucleocapsid. Okay, these are structural proteins. At the same time, it has non-structural proteins. Non-structural proteins. The non-structural proteins are going to be ORF1A and B. 1A and 1B. So what is this ORF? ORF is open reading frame 1A and 1B. Okay, 1A and 1B. Okay, 1A and 1B. Okay, so these are the things which you get to see here. Okay, so this is very, very important for your virus uh, understanding, because these are have specific roles in certain things. Okay, so this spike protein is the one which will attach to the receptor in the human cells in the alveoli called ACE2 cells. Okay, ACE2 cells, angiotensin converting enzyme 2 cells. Okay, and this is aided by another one protein which is present here. Okay, another one protein which is going to be present here. Okay, means another one protein will be present here, which is going to be aiding the attachment. Okay, which is going to be a sister helping the uh, uh, brother to get attached to the ACE2. Okay, and that is going to be called as TMPR SS2. TMPR SS2. Okay, so this is the very, very important thing. Okay, so this is called spike protein, which is or facilitates the entry of virus by attaching to ACE2 of the host cell. Okay, host cell. Okay, and next is your membrane protein, which is very, very important. And the third one is envelope protein. Okay, so which is very, very important thing. And the last one, okay, the last one is going to be your nucleocapsid. Okay, so this nucleocapsid is the one which interferes with host response mechanism. Host response mechanism. Okay, it interferes with the host response mechanism. Okay, so this is going to be very, very important thing. Okay, very, very important thing. So this is about the structure of the virus. Okay, this is about the structure of the virus. Okay, so the structure is very, very important. Okay, very, very important. Okay, so with this we will go into the next part. Okay, next part, where whenever you are we'll go into the pathogenesis. Whenever your S protein binds to ACE2 receptor, okay, what is going to happen? There will be a conformational change, which causes the virus to fuse with host cell and release RNA into host cell. RNA into the host cell. Okay, it will make the RNA to get enter into the host cell. Okay, that is the one. Okay, video. TRMPS is a protein. Just remember, it is a protein. Okay, it is a protein which helps in, which is present in the. Okay, so here the what is going to happen is the virus will fuse with the host cell. Okay, when the virus fuses with the host cell, what is going to happen is it is going to release the RNA into the host cell. Okay, and this RNA is going to be converted by viral replicase. Okay, to polyproteins. Okay, these polyproteins are cleaved into smaller proteins, and from here we are going to get the virus getting assembled into a new virus. Okay, like that we have lot of virus getting released. Okay, okay, so here whenever the virus replicates, okay, this is going to happen in the alveoli. Okay, whenever it happens in the alveoli, it is going to, what it is going to do is, in early phase
what it's going to result is, it is going to cause direct virus related mediated injury. In late phase, what is going to happen is, it is going to trigger an immune response where there is going to be stimulation of the T cells. Okay, when T cells are stimulated, it is going to cause release of cytokines. Okay, the cytokines which are getting released is going to be TNF alpha, okay, GM-CSF, okay, GM-CSF, okay, interleukin 1, okay, interleukin 6, okay, interferon gamma. So all these are going to cause damage to the alveolar cells, further resulting in a condition which is going to be called as cytokine storm. So there is going to be sudden release of all these cytokines, okay, and this cytokine storm is going to cause local and systemic inflammatory response. Whenever there is a cytokine storm, what is going to happen is, there is going to be injury to the alveoli. At the same time, there is going to be injury to the endothelium in the form of endothelitis. Okay, endothelitis. Whenever there is an injury into the endothelium, it is going to form lot of microthrombi. Formation of microthrombi. Okay, and this microthrombi is going to cause further damage to the alveoli, okay, by causing release of inflammatory cells into the alveoli, okay, by increasing the vascular permeability, vascular permeability, okay, and this causes further damage to the alveoli. So here what is going to happen, there is going to be an early phase where there is a direct virus mediated injury, and late phase only your patient is going to have involvement of all the cytokines, and that is going to be called as your very important cytokine storm. Okay, the cytokine storm is the one which is responsible for worsening of the patient condition. Okay, worsening of the patient condition. Okay, patient condition. So that is very important, very important thing to know. Okay, so what are the things which are happening after these destructions are happening? Okay, so what is the clinical feature? Okay, clinical feature of your COVID-19. So every one of you, or every one known to you, okay, most of the time they would have developed something called COVID. Okay, so without COVID, no one would have, most of them would have not escaped 2020 or 21. Okay, every one of us would have had COVID. Okay, so what clinical feature the patient can present to you? Okay, so the incubation period of this COVID is going to be somewhere around 2 to 14 days. Okay, the incubation period is 2 to 14 days. So without COVID, no one would have lived life in 2020 and 21. Okay, and for that reason only, the quarantine period is going to be 14 days in COVID. Okay, COVID is 14 days. So the incubation period is around 2 to 14 days, and the median incubation period is 5 days. Our average is going to be 5 days. Okay, so what is the infectivity period? Okay, the infective period is, the symptoms arises, okay, 2 days before the symptom arises and last up to 8 days after onset of symptoms. So the infectivity arises 2 days before the onset of symptoms, and the patient is going to have the ability to spread infection after 8 days of, up to 8 days of post symptoms onset. Okay, post symptoms onset. Okay, so this is very important thing. Okay, very important thing. So more or less this is going to end up like an ARDS. Okay, end up like a ARDS. Okay, so that is very important thing, and all these phenomena are due to the cytokine release. Okay, which occurs due to interleukin 6 and TNF alpha, which occurs due to interleukin 6 and TNF alpha. Okay, so this is the pathophysiology of your patients having COVID-19. Okay, COVID-19, and clinical feature, the patient is going to have clinical features which are going to be very non-specific clinical features. Okay, non-specific clinical features, but they say it involves all the organs actually. Okay, all the organs. So if you see, it involves the from brain till the GI tract. It is going to involve all organs most of the time. Okay, due to cytokine storm will increase the symptoms. Okay, the primary symptoms are due to the virus direct effect. Cytokine storm will cause worsening of symptoms. Okay, worsening of symptoms and prolonged symptoms. Okay, ARDS like feature. Okay, so what is the clinical feature? The patient is going to come to you. Okay, so the patient is going to have a initially a prodrome phase. Okay, prodrome phase, where patient is going to have mild symptoms. Okay, mild symptoms. So on day one, the patient is going to come to you with fever, which is usually low grade. Okay, cough, which is dry cough. Fatigue can be present. This is the primary complaint. Okay, and followed by the patient can have loss of smell. Okay, loss of taste. Okay, loss of smell, loss of taste. Then patient will develop shortness of breath. Okay, and ultimately they can have happy hypoxia. Happy hypoxia. So I have told you in our class what is happy hypoxia. When patient is sitting, patient is comfortable. When he starts walking to bathroom, he develops giddiness and falls. Why so? It is because of exertional interstitial involvement. Okay, understood, right? Okay, and this will be associated with these features, and what you're going to do is you're going to confirm it. Okay, how will you confirm it? Whenever you do a lab test, the lab test will confirm it as a COVID or not. Okay, so confirmed case is the patient is being confirmed with nucleic acid amplification test with RT-PCR. RT-PCR, that is going to confirm it. Okay, that is going to confirm it. Okay, and in patients with COVID, they were having a food. Okay, this is that big toe. In the big toe, the patients were having a purple thing like this. Okay, the purple toe like this, and this is called as COVID toes. COVID toes. Okay, this is because of the microembolize. Okay, microembolize reaching the small vessels. Okay, small vessels. Okay, this is actually a late feature in COVID. COVID. Okay, this is called as COVID toe. Okay, apart from this, the patient can have lot of atypical manifestations. Patient can present with hemoptysis, pulmonary embolism, GI features like diarrhea, vomiting. Okay, conjunctivitis. Okay, lot of atypical features are there. So these things were very important before 2022, but now they won't ask questions on this, I think so. Okay, so this is very important thing. Okay, next important thing, which is even would have been told in ENT, which is called mucormycosis. Whether it was told in ENT microbiology, Yes, ENT it was told. Whether you want me to cover this or you want to skip me to skip. So mucormycosis, okay, it is also called as zygomycosis. Want to skip? Okay, I'll skip this. Okay, so I will skip mucormycosis. Okay, so no sir means what is the meaning of no sir? Okay, so here mucormycosis. Okay, mucormycosis. So this is also called as zygomycosis. Okay, zygomycosis. Okay, it is caused by a group of fungi called mycetes. Okay, so whenever a patient is coming to you with history of diabetes mellitus, okay, history of diabetes mellitus, or whenever a patient has a defective or decreased immunocompetency, okay, like patient is coming to you with neutropenia on steroids, okay, or conditions where there is increased iron. Okay, very important thing. Whenever there is increased iron, conditions with increased iron, then these patients have high chances of developing, okay, uh, mucormycosis. Okay, so whenever a patient with DKA, a question is given where patient is having DKA, then that patient definitely can have mucormycosis. Okay, mucormycosis. Okay, so what is this? Why this is important? Okay, whenever a patient is having steroids, for example, even COVID patients were on steroids. Okay, and he is a known case of diabetes, and he is having COVID-19. Okay, so what this is going to do? The steroids and diabetes is going to cause increase in the glucose. Okay, and what is this going to do? It is going to increase the risk of mucormycosis. Okay, and COVID-19 will increase the cytokines interleukin 6. Okay, and this interleukin 6 has a function to increase ferritin. Because of this, there is going to be increase in intracellular iron. Okay, and this intracellular iron can result in growth for the fungus, which is going to be mucormycosis. Okay, mucormycosis. Okay, so any condition where there is going to be increase in the iron, okay, so that is going to result in, okay, and it is risk increases whenever the patient has dysferrioxamine. Okay, why dysferrioxamine is this? Dysferrioxamine is this one, which is go and chelate with the iron. It chelates the iron, okay, and it attaches to the fungal cell wall. Okay, it attaches to the fungal cell wall, and this dysferrioxamine creates a sideropore. Okay, this is called a sideropore or chinna ota sideropore, and it will deliver the iron to the fungus. When it delivers the iron to the fungus, this iron acts as a growth factor for your mucormycosis. Okay, mucormycosis can occur. Okay, so this is very important thing. Okay, very important thing. Okay, so there are different kinds of mucormycosis. Here can be rhino-ocular mucormycosis, pulmonary mucormycosis, cutaneous mucormycosis, GI mucormycosis, disseminated mucormycosis. Lot of mucormycosis are common. Okay, so when you will suspect rhino, orbito, cerebral mucormycosis. Okay, so whenever a patient is coming to you with nasal blockade, patient complains of nasal blockade or congestion, and this mass will compress the nerves nearby, and it is going to cause facial numbness. Facial numbness. Okay, and slowly what is going to happen is the patient will have loosening of teeth. Loosening of teeth. Okay, followed by it will enter into the orbital vessels, causing blurred vision. Blurred vision. Okay, that is how you will suspect patient is going into mucormycosis. Okay, mucormycosis. So the patient, since it is immunocompromised, lot of times what will happen is the patient will not have fever at all. Okay, slowly it will propagate, and ultimately it can go to cortical vein thrombosis. It can result in CVT. Okay, so whenever your patient is there, what is happening here is they are going to develop black eschar here. Black eschar. A black eschar like this. Okay, whenever this black eschar is there, you have to suspect mucormycosis. Okay, what is the investigations you can do? Investigation of choice is going to be MRI. Okay, cortical vein thrombosis. Cortical vein thrombosis. Okay, investigation of choice is going to be MRI. Okay, and MRI will give an idea that patient is having a mass which is extending into the deeper tissues. Okay, then followed by you can go for biopsy. Okay, biopsy will show thick ribbon like aseptate hyphae. Aseptate hyphae. Okay, and the important thing about this thing is they branch at right angles. Branch at right angles. Okay, so in your question, if they give the biopsy shows the fungal growth which the fungus branches at septate hyphae branches at 90 degrees. Okay, then you have to think about mucormycosis. Okay, mucormycosis. And how we are going to stain this mucormycosis? You are going to stain by KOH mount. KOH mount. Okay, KOH mount. Okay, so KOH mount, you are going to mount the biopsy specimen, and you are going to see what kind of growth it is, and it is going to show aseptate hyphae at 90 degrees. Okay, 90 degrees. This is very, very important. Okay, very, very important. Okay, or you can also go for another one test. Okay, another test called Moldy-Toff. Moldy-Toff. What is Moldy-Toff? Is matrix assisted laser desorption ionization. Okay, so this is one thing which is going to be a non-invasive procedure. Okay, non-invasive procedure where you are going to use a laser desorption. Okay, which is going to pick up the presence of fungi. Okay, which is going to pick up the presence of fungi, and this is called as Moldy-Toff. Okay, Moldy-Toff, if the center is available. Okay, if the center is having this, then you can go for it. Okay, then you can go for it. Okay, so this is about your mucormycosis investigation. The next step is treatment. Okay, the first and important thing is decrease the blood sugars. Blood sugars. Okay, blood sugars. Okay, then reduce the dose of steroids and discontinue other MAB drugs or JAK kinase inhibitors, which I will tell you later. Okay, so you stop these drugs. Okay, then you are going to go for treatment which is liposomal amphoby, which is more preferred than amphoby deoxycholate. Liposomal amphotericid B, which is more important than amphoby deoxycholate. Okay, so why this is important is this amphotericin B, liposomal amphotericin B has less side effect, okay, less side effect, less renal worsening, okay, with liposomal amphotericin B, okay. And if you want any other to be added whenever the patient is not intolerant to amphotericin B, because you have to monitor potassium and you have to monitor the creatinine every day in patients with liposomal amphotericin B. For that reason, you can go for posaconazole or isvaconazole. So posaconazole or isvaconazole are the two drugs which is going to be given as oral treatment in patients with mucormycosis, okay, whenever they are not responding or not tolerant to liposomal amphotericin B because of the side effect profile of amphotericin B, okay. So that is very, very important, okay. So how to prevent it? Keva, potassium, creatinine, okay, creatinine, okay. So how to prevent it? Okay, don't use steroids in patients with normal oxygen saturation, okay, normal oxygen saturation, okay. If steroids are indicated, if you're going to use steroids, okay, the steroid should be given at a dose of isvaconazole. If there is a no response, then you go for it. See, liposomal amphotericin B and amphotericin B deoxycholate has high chances of hyperkalemia and it is having high chances of causing AKI. Okay, so always monitor for potassium and creatinine. Okay, if there is no response or contraindication to these drugs, then you go for posaconazole and isvaconazole. Isvaconazole, same conazole, isvaconazole. Okay, if there is a requirement for steroids, okay, then you give Dexa 0.1 milligram per kg per day for 5 to 10 days, not more than that, okay. Stop Dexa as early as possible, stop Dexa as early as possible, because this is a deadly condition, okay, this is a deadly condition. For that reason, you should be very careful whenever you give steroids in diabetics, and this is not only seen in COVID, even in general patients, you should be very careful when you give steroids for long term in patients with diabetes, okay, diabetes, okay. So how you are going to investigate a case of uh, COVID, okay. So whenever you have any patient with COVID, okay, you can divide the patient based on clinical features as cat A, B and C, okay, where cat A is patient is having mild sore throat, cough, rhinitis. Cat B is patient is having fever plus cat A, okay, and patient is having risk factor for COVID, which we have discussed already. Risk factors for COVID. So, at what dose would tapering of steroids is required? What dose means? If you are going to give for more than 5 to 7 days, okay, then you have to go for tapering. When you're going to give for more than 7 days, you have to taper. Maximum 10 days, not more than that. Okay. And cat C, whenever patient has shortness of breath, chest pain, decreased BP, hemoptysis, cyanosis, they are going to be considered cat C patients. Okay. Now, You are going to divide this patient as mild, moderate, severe. Okay, mild, moderate, severe. How are you going to divide the patient as mild, moderate, severe? Mild, moderate, severe. Hope you copied this, right? Copied. Mild, moderate, severe. C, category C, cat C patients. We'll see, because based on that you are going to give treatment. Okay, so SpO2. Okay, hey, this is for COVID, man. We have already finished the treatment. We have already finished the this thing. This is for COVID. Okay, SpO2. Okay, whenever your SpO2 is 95% or more than 94% on room air, 90 to 94% on room air, less than 90% on room air. Okay, then next is respiratory rate. You are going to check less than 24, 24 to 30, more than 30. See, desferrioxamine will bind to the iron, and desferrioxamine, whenever it binds to iron, it will have high affinity towards the fungus. Okay, and this desferrioxamine will go and attach to the fungal side pore if fungus is already present. Okay, and it is going to make the iron to enter into the fungus and make the fungus to yield more budding. Whenever there is more budding, the fungal infection spreads rapidly. Okay, then symptoms. Symptoms of cat A, cat B, cat C. Okay, chest X-ray, normal, pneumonia-like feature involving one or two zones, and here more than two zones. Okay, CT chest involves less than 25% of the chest area. Here it is less than 50% of the chest area. Here it involves more than 50% of the chest area. Okay, so based on this, you are going to divide the patient into mild, moderate, and severe. Mild, moderate, and severe. Okay, so what are the investigations available for us? Okay, for us. So whenever a patient is having COVID, okay, so previously what we were doing is we see for parameters which will increase and parameters which will decrease. Okay, the parameters which were increasing were D dimer. D dimer in patients with COVID were more than thousands. The reason is it is an acute inflammatory condition where there is going to be increased clot formation and there is going to be increased release of FDP. Okay, then inflammation, CRP will increase, LDH will be increased. Okay, and it is known to cause necrosis of tissues. Because of this, troponin will be released. Okay, and ferritin here being an acute phase reactant will be more than 500. Okay, and there is going to be again muscle injury because of necrosis, the CPK level will increase. Okay, so these are few parameters which will increase, and the parameter which is going to decrease is going to be absolute lymphocyte count. Absolute lymphocyte count. Okay, and this absolute lymphocyte count with the neutrophils, we have a ratio called neutrophil lymphocyte ratio. Okay, when NLR is less than 3.5, the disease is considered as mild. Whenever the NLR is more than 3.5, it is going to be moderate to severe disease. Moderate to severe disease. Okay, moderate to severe disease. Okay, and especially whenever it is more than 5, it is going to be severe disease. Severe disease. Very, very important thing. The next important investigation is going to be interleukin 6. Interleukin 6. Okay, whenever interleukin 6 is less than 7, it is normal. Okay, less than 15 is considered as mild, less than 100 moderate, less than 500 severe, and more than 500 is critical. It is at picogram per ml, interleukin 6. Okay, interleukin 6 at picogram per ml. Okay, so the interleukin 6 is the one important thing which is going to tell you whether the patient is going into cytokine storm or not. Okay, so it can be a predictor of cytokine storm. Okay, it can be a predictor of cytokine storm. Okay, that is going to be your interleukin 6. Okay, interleukin 6 is going to be a predictor of cytokine storm. Okay, then what you're going to do is you're going to take the sample and you're going to send for diagnosis to confirm COVID. Okay, so what you're going to do is you are going to go for diagnostic investigation. So whenever you do investigation, you have two types of investigations. One is to confirm the current infection. One more thing is to know about the past infection. Whenever you want to know the current infection, you have two types of tests. Okay, antigen test. Another one is nucleic acid amplification test. Nucleic acid amplification test is done by RT-PCR. It is also done by TrueNOT or CB0. Okay, whereas if you want to know the past infection, then you have to go for antibody testing using serology. Okay, where you have IgM, IgG. Okay, IgG. Okay, so what specimen you will prefer? Okay, so whenever you have a patient coming to you with COVID, you will prefer ball specimen, which is 93% sensitive, followed by sputum, which is going to be 72%, followed by nasal swab. Okay, nasal swab, and followed by throat swab. But collecting throat swab is comparatively easy. Okay, for that reason we go for throat swab usually. Okay, throat swab usually. The reason is this one. Okay, but the best one is going to be your ball. Okay, so ball is better one than your sputum, and sputum is better one than your nasal swab, and nasal swab is better than your throat swab. Okay, understood? So this is how you will go for your testing. Okay, the methods of testing and all were like we used to tell about the type of bristles used and all, but as far as now we don't feel like it is very important. Okay, because it was during that peak time we had chances of asking questions. Okay, but now we have less chances of asking question. Okay, so one thing which can be asked in microbiology. Okay, whenever you transport the sample, you will transport the sample at 4 degrees Celsius. Okay, and once it reaches the lab, you can store the sample, and if you want to store for less than 5 days, you can store the sample at 4 degrees Celsius. If you want to store it for more than 5 days, then you have to store it at minus 70 degrees Celsius. Minus 70 degrees Celsius. Okay, so that is very important thing. Okay, very important thing. And one more thing, question which is can be asked in your PSM is going to be the biosafety. PSM and microbiology is going to be the biosafety level of different areas. Okay, biosafety level of different areas. There is something called BSL 1, 2, 3, and 4 that can be asked in your microbiology. Okay, microbiology. So study about the BSL and its significance. Okay, significance. Okay, so these are the tests which is done. Okay, so what are the features the patient can develop? Okay, how the patient is going to develop? Okay, so what happens here is the patient on day 0 is infected. Okay, on day 5 he is going to develop symptoms. Okay, on day 7 he is going to be positive for IgM antibody. Okay, on day 14 he is going to become IgG positive. IgG positive. Okay, IgG positive. And day 28. Okay, day 28. 28. Okay, the infection will start disappearing, so that SARS RNA and antigen disappear. Okay, disappear. Okay, so the first 7 days where your IgM antibody starts appearing, this period is called as window period. Yes, where the patient have mild symptoms, antibodies have not occurred. Okay, so this is called as window period. Okay, during this period, the investigation what we can prefer is going to be RT-PCR for SARS antigen, that is COVID antigen, and RNA. So the first 7 days is called as your window period. Okay, or RT-PCR. Okay, RT-PCR. Okay, so this RT-PCR, what it does is, it is very important to identify the E gene. It identifies the E gene. Okay, E gene, and it also identifies the N gene. Okay, and there is something called RNA dependent RNA polymerase, that is also detected. So it is going to detect the SmartMan. In SmartMan, it is going to detect the E gene, N gene, and RNA dependent RNA polymerase. Okay, that is going to be detected. Okay, so that is how you do RT-PCR, where we are going to subject the nasopharyngeal swab. This nasopharyngeal swab is going to contain the virus. This virus RNA will be there, and from this virus RNA we are going to obtain the complementary DNA by reverse transcriptase enzyme, and the primers will be added, which will increase the number of copies of the complementary DNA. Okay, and it will tell that whether the virus is present or not. Okay, whether the virus is present or not. Okay, so that is very important. Okay, so what is this thing is going to do? The RT-PCR is going to detect the number of DNA copies. Okay, number of DNA copies, that is very important. Based on the DNA copies, you can tell whether the patient is having mild infection or increased infection. Okay, that is can be seen with this RT-PCR. Okay, RT-PCR. So RT-PCR mainly detects E gene, N gene, and RD-RP gene. Okay, RD-RP gene. Okay, so this is about your RT-PCR. Whenever you do RT-PCR, okay, RT-PCR, the report comes in CT value. Okay, the report comes in CT value. What is CT value? Any report if you take in done during COVID, and if you see, it will be written as CT value. Okay, CT value is number of cycles required to amplify the DNA. Okay, so number of cycles required to amplify the DNA. When number of cycles is low, it means that the patient has high viral load. High viral load. Whenever the CT value is high, that is more number of cycles are required to amplify. Okay, and it will be less viral load. Less viral load. Okay, and usually whenever the number of cycles is less than 25, then it requires high viral load. Okay, it means high viral load, and whenever it is more than 30, it means that less viral load. Okay, very important thing. Okay, so it is viral load, CT value. Okay, that is called a cycle threshold. Okay, cycle threshold. Understood? Cycle threshold. So whenever your patient is having a question is being given, a patient who was suspected for COVID underwent a throat swab and RT-PCR was done, and the RT-PCR report showed a CT value of 34. What is your next step? What is the next step? The patient is considered as less viral load, asymptomatic, or patient is going to consider as not having COVID and discharge the patient. Okay, discharge the patient, treat symptomatically. Okay, treat symptomatically. So this is called as your RT-PCR. Okay, so RT-PCR is one important thing which I want to inform you. Okay, inform you. So RT-PCR is very important. Okay, RT-PCR is very important. So if you know RT-PCR, okay, there can be one or two questions in RT-PCR coming to your exam. Okay, coming to your exam. So with this, we are finishing our RT-PCR. Then we will go into the next thing, which is going to be treatment. Okay, treatment. Coming to the treatment. Okay, so treatment, whenever you decide on treatment, okay, so it is again based on the severity. Okay, severity. Okay, so whenever it is going to be severe pneumonia, then you are going to go for treatment based on the profile available. Okay, so over these years, okay, over these 2 years or 3 years, a lot of things have been changed actually. Okay, changed actually. There were some treatment guidelines which are followed in 2019 and 20, but now we are not into much of those guidelines. Okay, and here and there we are going using drugs which are available. So just we have to know what is the treatment. Okay, what is the treatment? Okay, so whenever a patient has uh, high risk, okay, high risk factors like elderly age, patient having pre-existing heart disease, like those things. Okay, and patient is not hospitalized. Hospitalized. Then what we are going to do is we are going to go for a drug called ritonavir plus nirmatrelvir. Nirmatrelvir. Ritonavir with nirmatrelvir. Okay, and this should be administered within 5 days of onset of symptoms. Okay, 5 days of onset of symptoms. Okay, ritonavir with nirmatrelvir. Okay, then we have next drug which is going to be remdesivir. Okay, remdesivir. This was considered as the wonder drug, but it didn't do actually wonders. But it was considered as a wonder drug. Okay, and it should be given within 7 days of onset of illness. Okay, and this requires as an IV infusion. The side effect of this drug was expected to be hypersensitivity reaction. Okay, expected to be hypersensitivity reaction. Okay, then we have another drug called molnupiravir. Molnupiravir. Okay, so this is given whenever you have no other option available. Okay, whenever you have no option available. Okay, then you go for molnupiravir. Okay, so here whenever a patient is hospitalized, okay, and whenever after hospitalization patient oxygen requires increases, then what you're going to do is you're going to combine remdesivir with steroids. Okay, you're going to try remdesivir with steroids. Okay, steroids. So what is this remdesivir? Okay, remdesivir. This remdesivir is a drug which is a adenosine nucleotide analog. Not so. It is actually hepatotoxic. Include hepatotoxic. Rather, it is not nephrotoxic, it is hepatotoxic. You have to monitor LFT. Okay. So adenosine nucleoside analog. Okay. What it does is it inhibits RNA replicase. Okay. So thereby it decreases RNA synthesis and decreases RNA replication. So new viral synthesis is decreased. Okay, RNA and thereby viral replication is decreased. Okay, that is the role of remdesivir. Okay, and what DEXA will do? Steroids, DEXA will decrease the inflammatory response. Inflammatory response. Okay, then next is you can use drug which is going to inhibit interleukin 6. Okay, the drug which is going to be used is going to be tocilizumab. Tocilizumab. You can also use sarilumab. Sarilumab. Okay, sarilumab. Okay, so these are drugs which is going to decrease the interleukin 6, thereby it decreases the cytokine storm. Okay, or cytokine response. Okay, then you go for JAK inhibitor. JAK inhibitor. Okay, here we have drug which is going to act on JAK 1 and 2 and JAK 1 and 3. Okay, the drug which acts on JAK 1 and 2. Okay, it is going to be baricitinib. Baricitinib. And drug which acts on 1 and 3. Okay, and that is going to be tofacitinib. Tofacitinib. Okay, so it is used as a drug in combination with steroids. Okay, it is combined with steroids and given as a drug. Okay, so these are the major drugs actually found to be useful. Okay, otherwise we had lot of medications proposed in treatment of COVID, but nothing were useful actually. Ivermectin, budesonide inhalation, then they told chloroquine, they told favipiravir. Okay, and these drugs were not useful, and only these drugs were ultimately found to be useful in treatment of your patients with COVID. Okay, patients with COVID. So over the years, the plan of treatment have changed a lot, and ultimately we are going to be ending up with these group of drugs. Okay, ending with these group of drugs. Okay, they told chloroquine is useful. They told hydroxychloroquine is useful. They told one drug called calmostat is useful. Okay, then favipiravir, ribavirin. Okay, but nothing is actually useful. Okay, useful. Okay, so very important thing to know. Okay, so it is going to be hepatotoxic. That is one very important thing about your remdesivir. Okay, otherwise nothing much to know in the drugs available. Okay, drugs are available. Okay, so this is about the treatment of patients with COVID. Okay, and ultimately what you're going to do is, okay, ultimately what you're going to do, you are going to treat the patient and discharge the patient. Okay, after discharge, the patient might have an episode of COVID again in future. So what we are going to do is we are going to go for vaccination. 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 Where I told you first scenario. Okay, see, not hospitalized. Okay, not hospitalized. If you are going to give drug, okay, if you are going to plan for drug remdesivir, okay, it can be given. Okay, but it is not must. See, whatever we know, whatever we have acquired from COVID is limited knowledge about COVID. Okay, so it can be given. Okay, the benefit is best only when the patient is having oxygen requirement. Okay, whenever the patient is having oxygen requirement, then it is best use. Otherwise it can be tried. Okay, but we don't know whether it is beneficial or not. Only when lot of trials in last 2-3 years has shown that whenever oxygen requirement is there, then you go for remdesivir, then it have better uh, benefit. Okay, better benefit. Okay, so we have lot of drugs actually uh, been recommended during COVID time. Okay, we had something called COVID cocktail. Okay, COVID top cocktail, which is called as casirivimab. I'll write you one drug called COVID cocktail. Okay, COVID cocktail, but now it is not being used again. Okay, that there are two groups of drug here. Okay, one is called casirivimab with imdevimab. Imdevimab. Okay, Another one drug is Bomland Nivimab, okay, plus Etesevimab. Casirivimab, Imdevimab, Bamlanivab, Etesevimab. Okay, these are the drugs which are also called as COVID cocktail. Okay, COVID cocktail, which is given as a cocktail injection, IV infusion. But now we are not again not sure about how good it is. Okay, so this is this Bamlanivab, Etesevimab is going to be targeting spike protein. Okay, and this Casirivimab and Imdevimab will target the RBD, receptor binding domain. Okay, receptor binding domain. But these drugs have been marketed, they were brought into market, and suddenly they were withdrawn. Okay, so that kind of drug. Okay, actually, this Casirivimab, Imdevimab became famous because Trump took this cocktail. Okay, and it became very famous. Cocktail means combination. Okay, Casirivimab, Imdevimab. Then again, they withdrew the drug. So they were not sure what drug was how much effective it is. Okay, it's been tried. It is like hit and go only. If it hits the target, then it is a good drug. If it is not hitting the target, then it is not a good drug. Like that only, we have developed a lot of medications during COVID time, and which one was life saving only, actually God knows. Okay, otherwise we don't know which drug was effective, which drug was not effective. And there was something called convalescent plasma. Okay, convalescent plasma was again tried in these patients, okay, during COVID time, and after few weeks they withdrew convalescent plasma. Okay, convalescent plasma means patient who recovered already from COVID, their blood will be taken, their plasma will be taken, and their plasma will be transfused to the uh, infected person. Okay, so it means that the antibodies will be there in the plasma, which will prevent or counteract the infections. Okay, but now then they told it is not useful, they withdrew it. Okay, then another thing was awake proning. I have told about awake proning during our ARDS class also. So patient has to turn positions, okay, prone, supine, intermittently. So that is going to be effective. Okay, that is going to be effective. So this is receptor binding domain. Receptor binding domain, where your virus meets the host. Okay, virus meets the host. Okay, then another thing before this, I will tell another one thing which is called long COVID syndrome. Okay, whenever a patient has persistent symptoms, which may be loss of smell, fatigue, etc., for more than 4 weeks, it is called as long COVID syndrome. It is called as long COVID syndrome. Okay, so this is called as long COVID syndrome, where the symptoms were persistent for more than 4 weeks. It is called as long COVID syndrome. Okay, then the next important thing which I want to talk here is going to be vaccine. Okay, vaccine. Okay, so whenever you take the vaccine in COVID, there are different types of vaccines are available. Okay, there are different types of vaccines are available. Okay, so based on this, the vaccine type, the efficacy was different in different groups of vaccine. Okay, so what are the vaccines available? Okay, vaccines available. So first vaccine, what they told. Once you copy, please let me know. So whenever you have vaccine, we have different groups of vaccine. Okay, so we have inactivated vaccine. Inactivated virus vaccine. What is this inactivated virus vaccine? Okay, so what is going to happen here is the genetic virus of the material is destroyed. Okay, and then what happened is this virus is given to the human. Okay, so this is the virus, for example. This virus genetic material is inactivated. Okay, and this virus now given to the human. Okay, it will be taken up by the antigen presenting cell. Okay, and whenever it is taken by the antigen presenting cell, what will happen? It will present to the T cell, and T cell will stimulate the B cell, and antibodies will be produced. Okay, this is called as inactivating virus vaccine. Okay, inactivated virus vaccine. Okay, this is one kind of vaccine. Okay, so this is the inactivated one. Okay, then the next group of vaccine which is being prepared, okay, which is called as viral subunit vaccine. Viral subunit vaccine. Viral subunit vaccine. Okay, so what happens here is the SARS-CoV antigen. Okay, this is separated. Okay, the SARS-CoV antigen is separated, and it is added to a adjuvant. Okay, adjuvant. So adjuvant is a material which will carry this antigens. Okay, so it is added to an adjuvant. Okay, and what will be the what it will happen is it will be given to the human body. Okay, again it is going to same thing: T cell, B cell, antibody. This is called viral subunit vaccine. Okay, and the third group of vaccine is going to be viral vector vaccine. Viral vector vaccine. Viral vector vaccine. Okay, what is this viral vector vaccine? So you are going to have a vector. Okay, so this is a non-coronavirus. For example, non-coronavirus. In this non-coronavirus, there is already one genetic material. In this genetic material, you are going to add the coronavirus genetic material. Coronavirus genetic material. Okay, what will happen? This will enter into the human body. It will multiply into lot of newer materials. These newer materials will contain the viral protein from the coronavirus, and what will happen? Against this, antibodies will be produced, and this is called as viral vector vaccine. Okay. Okay, this is called as viral vector vaccine. Okay, the last one is going to be RNA vaccine. RNA vaccine. RNA vaccine. Okay, so here what we are going to do is we are going to take the RNA strands. RNA strands. Okay, these RNA strands are taken and they are made as a lipid coat. Okay, lipid delivery vehicle, and it is given to the host or the human. Okay, where this RNA will go and multiply. Okay, and what is going to happen is it is going to induce the T cells. Induces T cells. Okay, and whenever T cells are induced, what is going to happen is it is going to be stored in memory. Okay, and it is going to be activating the B cells. The B cells are going to produce antibodies. Okay, and it is going to be stored in the memory. And whenever the virus comes, new virus comes, this virus will be activating this memory cells, and cytotoxic T cells will be produced. And these cytotoxic T cells will go and destroy the virus. Okay, will destroy the virus. Will destroy the virus. Okay. Yeah, antibodies are found in the host. Another vaccine எடுக்கிறோம். Vaccine எடுத்துக்கிட்டோம்னா vaccine what will happen is the vaccine will go inside. I mean, they'll go and multiply, and they will stimulate the host to produce antibodies. Okay, that is called as vaccination. So these are the groups of or types of vaccines we have. Okay, vaccine we have. Okay, so here in this, what are the vaccines which come under these things? Okay, so you know there are a lot of vaccines, right? So we have Pfizer vaccine. Pfizer vaccine, which is a RNA vaccine. Okay, and we have a French vaccine called Moderna. Moderna is a RNA vaccine. Okay, so our Covishield, okay, what you have put, what I have put, Covishield, okay, is going to be viral vector vaccine. Okay, viral vector vaccine. Okay, and AstraZeneca, US based. AstraZeneca is viral vector vaccine. Okay, then there is one vaccine produced in Russia, which is called Gamalaya or Sputnik 5. Gamalaya or Sputnik 5 is going to be viral vector vaccine. Okay, viral vector vaccine. Okay, then Johnson and Johnson is going to be again a viral vector vaccine. Okay, viral vector vaccine. Okay, viral vector vaccine. Okay, Johnson and Johnson. Then next is inactivated vaccine. Okay, in inactivated vaccine we have our Covaxin. So in children's less than 18 years, they were putting Covaxin, right? Covaxin is an inactivated vaccine. Okay, inactivated vaccine. Apart from this, we have other vaccines, okay, which is going to be DNA vaccine, plasmid DNA vaccine, which is more or less like our vector only, plasmid DNA vaccine. Okay, this one is going to be Zydus Cadila vaccine. Zydus Cadila vaccine. And we have another one, protein subunit vaccine. Protein subunit vaccine. And that is going to be Novavax. Nova is new protein. Okay, so remember Novavax is new protein. Zydus Cadila has D here, D here, DNA vaccine. Okay, plasma DNA vaccine. Inactivated virus. Okay, inactivated virus means co-vaccine. 18 years gets inactivated virus vaccine, which is co-vaccine. And next is viral vector vaccine, Covishield, AstraZeneca, Sputnik 5, and Johnson & Johnson. RNA vaccine is Pfizer and Moderna. Okay, Pfizer and Moderna. Okay, Pfizer and Moderna. Okay, so these are a few things, okay, which is very, very important. You have to know. Okay, very, very important things we have to know about the vaccine. The question can be asked for you. Okay, identify the wrong match regarding the following COVID-19 vaccines. Pfizer, mRNA based vaccine. Covaxin, inactivated vaccine. Moderna, recombinant DNA vaccine. AstraZeneca, non-replicating viral vector vaccine. Yes. Protein subunit vaccine. What should be the answer? It should be D. Moderna. Moderna is a RNA vaccine, right? I told you recombinant DNA vaccine. What is recombinant DNA vaccine? What is recombinant DNA vaccine? Zydus Cadila, right? Zydus Cadila is DNA vaccine. Protein subunit vaccine. Protein subunit vaccine. Protein subunit vaccine is Novavax. Novavax. Okay. So these are few important things we have to know here. Okay, very, very important things to know here. Okay. So in this Pfizer vaccine is 2 doses, okay, to be administered, okay, and Moderna vaccine again 2 doses to be administered. Johnson and Johnson single dose, okay, and Sputnik 5 also they told 2 doses. Our Covishield was 2 doses, okay. So these are going to be different vaccines approved in different countries actually, okay. So that is very, very important thing. Okay, very, very important thing. Okay, and anything different you want to know? So nothing different between vaccines other than that. Okay, other than that we have nothing to tell. I think so in vaccines. Okay, but this classification is very, very important thing. Okay, very, very important thing to know. Okay, cytokine storm causes all of the following except, okay, acute respiratory distress syndrome, stroke, myocardial infarction, red hepatization of lung. It is red hepatization of lung. ARDS can occur because of cytokine storm, microthrombotic formation, stroke, myocardial infarction. But red hepatization occurs in which phase? The initial phase of the pneumonia itself, direct lung injury. Okay, understood? All of the following are serious predisposing risk factor for
COVID-19 except cancer, CKD, COPD, BMI of 20 to 25? Yes, waiting for your answer. Cancer, CKD, COPD, BMI 20 to 25. All of the following are predisposing factor for serious COVID infection except BMI of more than 30 is a risk factor, right? Everyone is there? Yes. Which of the following has been recognized as a significant risk factor for development of ARDS and death in patients with COVID-19? Decreased LDH, decreased D dimer level, neutropenia, lymphocytosis. What can be the answer? What happened? Neutropenia here. Okay. So increased LDH, increased D dimer, lymphopenia. Okay. And should be there. Okay. Here the best option is which one? I told neutropenia, neutrophilia. Okay. Neutrophilia is a thing which is going to happen. So you have to see for NLC ratio. How much NLC ratio is significant? How much NLC ratio is significant? More than? People are there or not? 3.5. Okay, 3.5. So this is very, very important. Okay, very, very important. So whenever patient is worsening, then it means that patient is having some altered features. Okay, altered features. Okay. Then one more question, if I want to ask you. Okay, which of the following statement is false? LMWH is helpful in patients with elevated D-dimer level. Dexamethasone is not effective in patients without oxygen requirement. Post-exposure prophylaxis with Kesrivimab and Imdevimab is an effective option. NSAID need not be stopped in patients with connective tissue disorders and can be used during COVID illness. So what is the answer? Answer is there is no post-exposure prophylaxis available for COVID. So that is going to be false. Okay. Dexa always the useful whenever patient is on steroid, patient is on oxygen, it is going to be useful. Okay. So answer is post-exposure prophylaxis with Casirivimab and Imdevimab is an effective option is wrong. Okay. Effective option is wrong. Okay. So, okay. Which of the following regarding SARS-CoV-2 is more accurate? Okay. First one, steroids are known to reduce the number of sick days in mild and asymptomatic patients. Favipiravir is substantially beneficial in patients with moderate to severe disease. Baricitinib should be used along with remdesivir. Convalescent plasma helps in quick recovery from ventilated patients. From ventilator in ventilated patient. Steroids, or which of the following is most accurate? Steroids reduces the number of sick days in mild and asymptomatic patients. Favipiravir is substantially beneficial in patients with moderate to severe disease. Baricitinib should be used along with remdesivir. Convalescent plasma helps quick recovery in ventilated patients. It should be steroids எங்க யூஸ் பண்ணுவீங்க? Where you will use steroids in patients with moderate to severe disease with oxygen requirement. Favipiravir, I told you, not useful. Even though if you're going to use it, it is useful in mild diseases. Baricitinib, what I told you here, where I told you. Okay. Whenever you are going to use any kind of NIPS, okay, any kind of NIPS, use it with steroids. Okay. Whenever you want to use any NIPS, use it with steroids, it is effective. Okay. Use NIPS with steroids, effective. Okay.
So this is about few things about your this thing. Okay. So false regarding the mechanism of COVID-19 drugs. Okay. Tocilizumab interleukin 6 receptor antagonist, baricitinib JAK inhibitor, ivermectin inhibits nuclear import protein, IMPA, MERS-CoV, casirivimab and imdevimab against TMPRSS2. It's a monoclonal antibody against TMPRSS2. 4 options. What should be the answer? Tocilizumab. Which of the following is false? Interleukin 6 receptor antagonist, tocilizumab. Ivermectin inhibits nuclear import protein. Baricitinib is JAK inhibitor. Ivermectin inhibits import protein. Casirivimab, imdevimab against TMPRSS2. So here I told you what is casirivimab, imdevimab, where it acts in receptor binding domain. Okay, so answer is going to be D, receptor binding domain. Okay. Okay. 32-year-old male patient. Okay, diagnosed as COVID pneumonia, was on home quarantine for last 5 days. He was feeling little tired, and his SpO2 is 92% on room air. Respiratory rate is 20 per minute. BP 120/70. What you would advise him? Continue observation with SpO2 monitoring. Admit in ICU and start high flow nasal cannula oxygen. Admit immediately in a dedicated COVID center and give subliminal oxygen. Prone ventilation in home will be helpful. What are you going to do? So whenever a patient who was well before, okay, that is on day 1, day 2 he is well, and worsening of saturation on day 5, okay, it means patient can worsen, okay, can worsen. He requires observation, okay. So if the patient can be monitored, the patient should be monitored frequently with the saturation, and if there is any worsening is there, then the patient should be admitted for supplemental oxygen. So this is again little contradictory type of question. Okay, so it depends. If it again this question depends upon the physician actually. Okay, so this is coming under which one? Mild or moderate or severe? This is coming under moderate. Okay, moderate. Okay, so moderate patients are can anytime worsen. So you should be very careful in those patients. Okay, so monitor his SpO2. If there is a worsening, then shift the patient to hospital to get admitted. Okay, that can be done. Okay. Then next is what is the median incubation period of COVID-19? So patient should be observed and then worsening is there, then admitted. Okay. So median incubation period of COVID-19. Median incubation period of COVID-19 is 14 days, 10 days, 4 days, 28 days. 14, 4, 10, 28. It is going to be 4 days, right? 4 days. 4 days. Okay. Now, the virus responsible for COVID-19 belongs to which family of coronavirus? Alpha, beta, gamma, delta. Which family of coronavirus? Which family of coronavirus? Alpha, beta, gamma, delta. It is beta. Okay. Then the most common hematological abnormality reported in severe COVID-19 patients: thrombocytosis, leukocytosis, thrombocytopenia, leukopenia. It should be leukopenia, right? Leukopenia. Leukopenia. Leukopenia is the answer. Okay. Which of the following parameters is not included in moderate case? SpO2 90 to 94, respiratory rate of more than 60 minutes. Okay. In child, less, okay, 60 minutes in a child, respiratory rate of more than 30 in adults, and fever, cough, and dyspnea. Child, we don't know. Okay. So we'll see the adults. Respiratory rate of 30 in adults is not included. Okay, not included. Okay. So it is going to be how much? More than 30 is going to be severe. More than 30 is going to be severe. Okay. So that is very, very important. Okay. So these are few questions which can be kind of questions, because we don't know. We don't have any definitive question pattern here. Okay. So one more thing. One last question. What is the scoring system in CT in patients with COVID? Any idea? It is called cohort scoring. Okay. Cohorts. CT find. CT scoring is called cohort scoring. Okay. Cohorts. So these are few things about your COVID. Okay. Since they would have discussed about uh, discussed about cohorts and all in yeah, I will clear the doubt. Okay. So cohorts in radiology, I'm not touching it. Okay. Last question. A 40-year-old man presented with flu-like illness. Okay. Yeah, 2 to 14. Average is 5, right? I told you 5 days. Am I correct? So 5. So nearby 5 is 4. I told you, right? Medium incubation period. Yes, I think so. Right. Okay. A 50-year-old man presented with a history of fever and myalgia. He had exposure to a confirmed case of COVID-19, and he rushed to hospital where a sample was collected for RT-PCR. However, due to some transportation issues, the sample cannot be processed for another 5 to 6 days. Under what temperature the swab can be stored to not to affect the test result due to delay in performing the test? Minus 70 degrees Celsius. Okay. So these are few things which I want you people to remember. Okay. Very, very importantly. Okay. And one more question. SARS-CoV attaches to host cell by binding to which receptor? ACE1, ACE2, ET1, ET2. ACE2. Okay. So these are few things which I want you people to remember. Okay. So there are a lot of things to discuss in COVID, but we try to stick on to few things which is very, very important. Okay. Very, very important. So with this, we will finish COVID. Okay. Then we will go into the next discussion, which is again one of the important topics for your exam. Okay. Important topic for your exam, important topic for your life, and important topic for India. Okay. Which is going to be tuberculosis. Okay. So for you in your place, I will give you 2 minutes break. Okay. Relax 2 minutes. Again, we'll start. We'll start. So we'll finish some part of TB, and then we'll go for lunch break. Yeah, ask me, Dr. Nandini. See, I told you, no, there is microthromboid formation. Frequency is usually not so important. Not important. 4 weeks gap is there. For each vaccine is very different. In India, it is 4 weeks. You remember that. Okay. For SAR, in some places they use anticoagulants. Yeah, it is beneficial because I told you, no, there is microthrombi formation. To prevent those microthrombi from entering into the circulation, we require anticoagulation. It's a thrombogenic state. Okay, thrombogenic state. No, sarcoidosis is not planned for today. Post-COVID, not so important. That long COVID is important. Long COVID is very important. Sarcoidosis. See, whenever it is none of the above, that answer is wrong. First thing, all of the above will be 75% time
80% of time it will be wrong. Okay, so don't go for it. Yeah, to avoid all of the above is ideal. Neutrophilia will be there. Okay, neutrophilia will be there, but you do have, whenever the severity increases, you can have neutropenia. Whenever severity increases, you can have neutropenia, but neutrophilia is more common. That only will cause NLC ratio increase. Okay, more importantly, lymphopenia. So in 1 minute, we'll start back again. Viral vaccine is here. Okay, so we will go into the next topic. Okay, which is going to be tuberculosis. Okay, tuberculosis. So with tuberculosis, and we will do HIV. We will finish, I think so. So we'll go for tuberculosis again. It's very important to know tuberculosis. So how we are going to approach tuberculosis? So a patient is coming to you, and that patient is going to have history of cough, fever, and evening rise of temperature, sweating, loss of appetite, loss of weight. Okay, so how this fellow developed this and how this disease progressed. Okay, so whenever you have tuberculosis, the first thing which have to come to your mind as a medical student is World TB Day. Okay, when is World TB Day? When is World TB Day? It is March 24. Okay, this was again an MCQ. Okay, this was again an MCQ. It is March 24. Okay, March 24. March 24. Okay, so what is tuberculosis? Okay, this is an infection caused by Mycobacterium tuberculosis. So that fellow has gone for uh, infection with Mycobacterium tuberculosis, and this Mycobacterium tuberculosis can cause pulmonary TB and extrapulmonary TB. Extrapulmonary TB. Okay, this infection transmits by droplet infection. Okay, droplet infection. Okay, droplet infection. So whenever it spreads by droplet, it requires at least 10,000 organisms per ml of sputum to produce infection. Okay, so this is the minimal infective dose. It is going to be droplet infection. It can also spread by milk, by Mycobacterium bovis. It can also spread through skin contact. Skin contact. Okay, skin contact. Okay, skin contact. So this Mycobacterium tuberculosis is a bacilli which contains a cell wall, and this cell wall contains a thing which is very important. Okay, which is called as mycolic acid. Mycolic acid. The mycolic acid is the one which resists gram staining, making this organism acid fast bacilli. Okay, this is because of this bacteria is not going to be stained by gram staining. It is a gram neutral. Even though our books use in gram positive organism, it's a gram neutral organism. Okay, and it is a facultative intracellular organism. Facultative intracellular organism, which is non-motile, non-sporing organism. It is non-motile, non-sporing organism. Okay, this bacteria has a slow generation time of 15 to 20 hours. Okay, so it doesn't move
it doesn't spore. Okay, it lives happily with a slow generation time of 15 to 20 hours. Okay, 20 hours. Okay, and this mycolic acid is the one which is going to give the property of acid fast nature. Okay, acid fast nature. And this virus, sorry, this bacteria has a virulence factor. Okay, virulence factor, and the virulence factor is called as Scott factor. And the Scott factor is nothing but a substance in the cell wall, okay, called as trehalose 6,6 dimycolate, dimycolate, okay, dimycolate. IC is intracellular organism, intracellular, intracellular, intracellular organism. Okay, so what lesion? Okay, we will come to that later. Okay, so this is going to be the thing. Okay, whenever a person, whenever a person is exposed to TB, whenever a person is exposed to TB, okay, by contact, by droplet infection, they are going to get exposed to TB, okay, and they are going to get initial infection. That initial infection is usually, initial response is going to be a hypersensitive reaction to the TB bacilli, okay, and out of these persons, okay, 5% of the patients are going to present as primary TB, okay, and 95% of the patients are going to be latent TB. Latent TB. This 95% of cases, whenever they have certain factors, okay, like diabetes, HIV, chronic disease, decreased immunity, okay. So out of these people, okay, 5% of cases are going to become secondary TB, which is going to be reactivation TB, okay, and 90% of cases are going to remain same as no disease, no disease. Okay, so this is the progression of the disease. Okay, so whenever you have any patient with exposure to TB bacilli, okay, so what is going to happen? Around 5% of cases are going to develop primary tuberculosis, and 95% of cases are going to develop latent tuberculosis. And these patients, whenever they are immunocompromised, 5% of cases are going to become secondary reactivated tuberculosis. Okay, secondary reactivated tuberculosis. So this is seen usually in patients who are going to be having malnutrition, HIV. Okay, malnutrition also can include malnutrition, DM2, HIV, chronic diseases, decreased immunity. Okay, so these people are going to develop full-blown tuberculosis. Okay, full-blown tuberculosis. Why this occurs? Okay, why this occurs? And what is the difference between primary tuberculosis and secondary tuberculosis? Okay, so in primary tuberculosis, it is seen in unsensitized individual. This hypersensitivity reaction. Once you copy it, please let me know. Okay, so now the patient is going to have unsensitized individual. Okay, this is the first time he is getting infection, whereas secondary TB is going to be a reactivation of TB, reactivation of already sensitized individual. Okay, the most common site here in our patients with primary tuberculosis is going to be middle zone. Middle zone. Okay, that is the most common site. The reason for involving middle zone here is middle zone is the one where you are going to have immediate blood supply and oxygen supply. So that is a zone of the lung which is going to have more chances of tuberculosis. Okay, that is primary tuberculosis. Okay, so it is going to be the middle zone. Okay, middle zone, which is going to be lower part of the middle zone. Okay, if it is going to be next option, then it is going to be lower zone, upper part of the lower zone. That is going to be the most common site to get involved. Whereas if you take the secondary tuberculosis, so we all know that it is going to be involving the apex. It is going to involve the apex. Okay, why apex? In apex, it is going to have more ventilation because of gravity decreased perfusion. So this increases the oxygen tension in this area. Whenever oxygen tension in this area increases, what is going to happen? The patient is going to have high chances of bacilli survival. Okay, bacilli survival. Okay, bacilli survival. That is very, very important. Okay, then next thing is the area of first contact, which I will discuss again later. There is a subpleural focus. Subpleural focus, and that is the area of first contact, and the subpleural focus is called as Gons complex. Gons complex. This Gons complex has radiating lymphatics, which goes from here and it goes and activates the lymph nodes here. And this is called as lymph node, lymphatics, and the subpleural focus is called as, so this is actually Gons focus. This is Gons focus, and this is called as Gons complex. Gons focus and Gons complex. Okay, whenever this focus gets calcification, whenever this focus becomes calcified, okay, this calcification is called as Ranke's complex. This is called as Ranke's complex. Okay, whenever this becomes calcified, okay, then it is going to be called as Ranke's complex. Okay, very, very important thing, which is going to be Ranke's complex. Okay, Ranke's complex. Ranke's complex is the one which is going to be a calcified primary focus. Okay, primary focus or Gons focus which gets calcified is called as Ranke's complex. Okay, Ranke's complex. Very, very important thing. Okay, very, very important thing. Okay, Ranke's complex. Next is in patients with secondary tuberculosis. Okay, there is a apical scarring with a fibronodular patch. Apical scarring with fibronodular patch. And this is called as Simon focus. Simon focus. Simon focus. Okay, and in patients with chronic tuberculosis, in apex, you get active lesions, okay, above the clavicle and active lesions below the clavicle. Okay, the lesion above the clavicle is called as pulse lesion. Okay, below the clavicle is called as Osman focus. Osman focus. Pulse lesion, Osman focus. Gons complex is Gons focus plus lymphatics plus hilar lymph nodes. Focus is a subpleural focus. Subpleural involvement. Subpleural lesion. Okay, it's going to be called as Gons focus. Whenever it spreads through the lymphatics to the lymph node, together it is called as Gons complex. Understood? Yes? Yes. Okay. Then you have focus over the meninges. Meninges. Focus over the meninges. Focus over the meninges. And this focus over the meninges is called as rich focus. Rich focus. So these are few focuses available. Okay. Now what happens? These are few focus available. Okay. And one more thing you should always remember, in secondary tuberculosis, I will discuss later also. In secondary tuberculosis, there will be, the mechanism I will tell you later, there will be a caseous material. Okay. And this caseous material is going to be surrounded by a granuloma. Okay. So this granuloma sometimes rupture, and it is going to form cavity alone. The caseous material will be taken out, and you will be having cavity. This is because of cell-mediated immunity, immune response. This is rich focus brain, meninges. Secondary TB only I'm drawing, no? In secondary TB. Okay. Whereas if you take the primary tuberculosis, you don't get a cavity. Okay, because the cell-mediated immunity is very poor here, and because of that, no cavity is found in primary tuberculosis. Very, very important point. No cavity in primary tuberculosis. Okay, no cavity in primary tuberculosis. Cell-mediated immunity. Clear? Cell-mediated immunity. What will happen because of cell-mediated immunity? That is going to be. I will explain it later. Wait. For time being, write this. I will explain it. This cavity is the most infectious one. Most infectious lesion. I will tell you how much bacteria is present, but for time being, write it as most infectious lesion. Most infectious lesion. Most infectious lesion. Okay. So coming to the next thing. Okay. Next thing, how this bacteria invades the human and how it causes the disease. Okay. How it causes the disease. Okay. Now what happens? This bacteria is going to be containing in its surface a cap called mannose cap. Okay, it contains mannose. What will happen is this mannose, okay, capped bacteria will come and bind to the host cell macrophage. Okay, and this receptor where comes and bind is called as mannose receptor. Mannose receptor. This binding is facilitated by N ramp. Okay, N ramp. This N ramp is the one which is going to facilitate the binding of your bacilli with the bacteria. Whenever there is N ramp polymorphism, our bacteria will escape phagocytosis. And what happens here? This bacteria will be taken up by the phagosome. Okay, phagosome, and there is going to be influx of hydrogen ATPase. Okay, this hydrogen ATPase. Okay, this hydrogen ATPase, what it will do is it will start killing the bacilli. After killing the bacilli, what will happen is this will combine with the lysosome. This phagolysosome fusion will result in your patient, okay, to kill the bacteria. Okay, kill the bacteria, and this is going to create a host response, which is mediated by cell-mediated immunity, and this response is called as Th1 response. Th1 response. Okay, this Th1 response is going to produce interferon gamma. This interferon gamma will increase the vascular permeability and increase the inflammation. Okay, at the same time, this Th1 response is going to activate TNF alpha. What this TNF alpha will do? This TNF alpha will stimulate the macrophages. These macrophages will cause granulomatous reaction. Whenever there is a granulomatous reaction, what is going to happen is, this is the macrophage, okay, and this macrophage will inside have the bacilli, okay, and this bacilli will combat with the human immunity, and it is going to produce a caseous material, caseous necrosis. And because of this caseous necrosis is going to have lot of bacilli within it, okay, and this is covered by a cap, okay, a cap of activated macrophages, a cap activated by macrophages, okay, and that is surrounded by a collar of Th1 lymphocytes. Is covered by a collar of Th1 lymphocytes. Okay, and this together is called as granuloma. Okay, this is called granuloma formation. Okay, and this granuloma has a layer which is going to be Th1 lymphocyte protected, and this is maintained by TNF alpha. This is maintained by TNF alpha. Okay, and this granuloma is also helped in formation by ESAT6. Okay, ESAT6 is the one which is going to be a stimulating factor in our human body, okay, that produces matrix metalloproteinases. Okay, and these matrix metalloproteinases, what it does is, it will cause fibrosis. The granuloma will go for fibrosis, heals with scar formation. Okay, or this granuloma will remain as a granuloma, okay, and this is going to be a hidden tuberculosis called as latent tuberculosis. Okay, latent tuberculosis. So this is the fate of your TB bacilli inside the human body, and the bacilli escapes the fusion of your macrophage by NRAM polymorphism. Okay, NRAM polymorphism. Okay, and your bacteria also prevents this ATPase, hydrogen ion ATPase, okay, by inhibiting this ATPase by producing a substance called PTPase. Okay, PTPase is a one which is produced by the bacteria which inhibits this H plus ATPase, thereby it prevents the destruction of the bacilli. Okay, then what happens? Your bacteria also prevents this phagolysosome fusion. Okay, it is done by cod factor. Cod factor inhibits this phagolysosome fusion. Okay, cod factor inhibits this phagolysosome fusion. Okay, and thereby your bacteria tries to escape from getting damaged by the phagocytes and lysosomes. Okay, Okay, so this PTPase is protein tyrosine phosphatase. Okay, if you want, you can write it. It's not important. If you want, you can write it. Okay, you can write it. Okay, so these are few things your body will try. NRAMP is actually not requirement. NRAMP is not required. Just you write NRAMP. Okay, NRAMP is not required. Okay, so these are few things which is because it's a very big thing. No, actually your body will try to kill the bacteria. Okay, and your bacteria escapes the killing by binding to uh, cod factor, and this cod factor will prevent this phagolysosome fusion. Okay, normally this response will happen. Okay, if this response is not happening, means your bacteria can survive, right? If this response is not happening, your bacteria can survive, right? See, simple. See, simple. Your bacilli is going to bind to the host macrophage, and this host macrophage will stimulate the Th1 response, and it is going to produce interferon gamma and TNF alpha. Okay, and this bacilli will be contained inside the macrophage itself. Okay, it see wait, I'll explain. Okay, so TNF alpha will stimulate the macrophages. Macrophages will cause granulomatous reaction. So this is the granuloma formation. Okay, so only in tuberculosis, what pathology? What they have told you? What kind of necrosis in tuberculosis? It's a caseous material. That caseous material contains your immune cells and your TB bacilli. Okay, it contains the immune cells and the TB bacilli. Okay, few TB bacilli would have been died, few TB bacilli would have been live. Okay, and it is surrounded by a core. Okay, what is that core contains? Macrophages. What are those macrophages are called as? Histocytes. And what is this whole thing is called as granuloma. Okay, PTPase is one which is produced by your bacteria. So this PTPase will prevent your bacteria getting killed by this hydrogen ion ATPase. What is hydrogen ATPase? What it produces? Hydrogen ion acid, right? It is killed. It prevents the killing of the bacteria from the acid. Okay, that is called as your PTPase. Okay, that is a function of your PTPase. Okay, PTPase. Okay, and your macrophage. Okay, macrophage will help in more amount of granuloma formation mediated by matrix metalloproteinases. Okay, matrix metalloproteinases. Okay, matrix metalloproteinases. Okay, so it is going to go and bind to the receptor. Okay, and this is facilitated. See, simple. If you want to eat a crab, what you will do? You will open the mouth and eat the crab. Okay, so for this, what happened? Your mouth should open and the crab should enter, right? Okay, how your crab will prevent from entering? What is facilitating it? Your teeth opening the mouth and teeth will facilitate. Okay, your teeth will facilitate it. Okay, imagine your teeth is your end ramp. Okay, whenever your end ramp is going to go for polymorphism, whether you can eat the crab. Yes or no? No. So the same thing happens whenever your body, your bacteria finds some method to create a end-ramp polymorphism and recurrent infection. Okay, what is going to happen? Your mouth cannot open, you cannot eat the crab. Okay, so it will escape, crab will escape. Okay, so ESAT6 is the one which will help in formation of granuloma. Okay, it is the one which is going to help in formation of granuloma. Okay, it is one which is actually this is present in the cell wall of MTP, and this stimulates your human body to produce matrix metalloproteinases, and that will help in formation of granuloma. Understood? Yes. Okay. So this is very, very important. Okay. This is very, very important. Okay. This is very, very important. So this is how your body will try to produce uh, a, a, a cascade of granuloma. Okay. So now you give TNF alpha inhibitor. What will happen? When you give TNF alpha inhibitor, what will happen? It will break open and the bacilli will come out. Okay. So bacilli will come out. For that reason, when you should not give TNF alpha in patient, because this is guarded by TNF alpha. Okay. When it is, yeah, it will form fibrosis, right, around the granuloma. Granuloma is maintained, no? Where is your granuloma? This is a granuloma. This can go into fibrosis, okay, and it can damage. Okay, it can be totally a fibrosed tissue, and it will heal and form a scar. Okay, that is called as fibrosis. How, sir? So few people who are rheumatology, what I told you, what precaution you have to do before starting TNF alpha. In rheumatology, what I told you before starting TNF alpha, what you're going to do to be ruled out, because whenever you give TNF alpha, what will happen? This TNF alpha antagonist, when you give, this outer layer will get broken. Okay, when it is broken, what will happen? TB bacilli will be released, right? When you give anti-TNF alpha. Yes? Okay. So these are few things which you have to remember. Okay, few things which you have to remember. Okay. So this granuloma formation is aided by ESAT6, which is in the TB bacilli cell wall. Okay. So this is about your pathophysiology. Okay. Now what happens? This TB bacilli, which is contained in the cavity of your lung. Okay, this will enter into the blood vessel. Okay, and whenever it enters into the blood vessel, it can go to the opposite lung, spleen, liver, and brain. Okay, and this is called resulting in miliary tuberculosis. Miliary tuberculosis. Okay, miliary tuberculosis is a distant metastasis through hematogenous route to different organs. Okay, so this is seen in 2% of cases of tuberculosis. Total tuberculosis cases, 2% cases is going to be miliary tuberculosis. This miliary tuberculosis can be two ways presentation. It can be an acute presentation or it can be a subacute presentation. Acute is very rare, it presents like ARDS, whereas subacute is most common form where it is going to involve, as I told you, multiple organs. Okay, and in patients with tuberculosis with biliary format, if you see the fundus, okay, this is the fundus, okay, and you have the vessels going here. Okay? The vessels will be going here. This is the fundus where you are going to see the vessels going here. Okay, here what you get to see is you get a blotchy area. Okay, blotchy area like this. Okay, blotchy area in miliary tuberculosis, and this blotchy area is called as choroid tubercles. Choroid tubercles, and these choroid tubercles are pathognomic of miliary tuberculosis. Okay, and if you take the microscopy sample, sputum sample of this patient and see in microscope, the sputum microscopy will be negative. It will not show any organism, and these patients will be MAN2 negative. I will tell you what is MAN2 and all. Okay, MAN2 negative. And if you do a chest X-ray or a CT scan, it will show 1 to 3 millimeter size nodules in all zones of lung. In all zones of lung, which resembles the millet. Okay, resembles the millet. So for that reason, it is called as miliary tuberculosis. If you see the lung, The lung will have lot of like this, lot of 1 millimeter size nodules. These are called, this will be seen all over the lung. Okay, this is called as miliary tuberculosis. Miliary tuberculosis. Okay, then there are variants of this miliary tuberculosis. Okay, variants. The first variant is called as cryptic miliary tuberculosis. Cryptic miliary. This was last year MCQ. Okay, so whenever you have any elderly patient with history of fever, anemia, weight loss is coming to you. Okay, whenever elderly patient is going to be having these features, what you will think? Features suggestive of malignancy. Okay, it presents like malignancy. Okay, and obviously the chest X-ray will be normal and your sputum will be negative. Okay, so this kind of picture will be there in patients with cryptic miliary tuberculosis. And if you see this patient will be having bad prognosis. Bad prognosis. Okay, the next variant is called as non-reactive miliary. Non-reactive miliary. In rare non-reactive miliary, it is a rare septicemic form of miliary tuberculosis, where patient will have some kind of hematological tumor, hematological malignancy or abnormality. That kind of patient where the patient is going to have features of tuberculosis, but no evidence of tuberculosis. Okay, features of tuberculosis, no evidence of tuberculosis. Okay, so these patients have no granuloma formation, no granuloma formation. They say before granuloma formation itself, patient will die. Okay, so there will be no nodules. Okay, so this is two variants. Okay, variants of tuberculosis, where one is elderly patient with miliary tuberculosis is called as cryptic miliary tuberculosis. Another one is hematological malignancy with the tuberculosis is going to be non-reactive miliary tuberculosis. Non-reactive miliary tuberculosis. Okay, tuberculosis. So these are the two variants of tuberculosis. Okay, now your patient is going to a market. Okay, and this fellow is having TB. Okay, and this fellow is talking to his friend. Okay, and when he talks, this fellow is having tuberculosis, is coughing, and when coughs, the TB bacilli is going to enter. Okay, and whenever it is going to be entering, it is called as reactivation of TB. So whenever the new TB bacilli comes, it will reactivate the old infection. Okay, old infection. Whenever there is a reactivation of tuberculosis, it is going to involve the upper lobe apical segment. Upper lobe apical segment. Okay, upper lobe apical segment. Okay, or it can involve the lower lobe superior segment. Superior segment. And if you see this fellow's lung will have a area where there is going to be tissue necrosis, caseous material. Okay, whenever the patient coughs out, this caseous material will be expelled out. Okay, expelled out, and it is going to have a cavity. This caseous material will contain 10 power 4 bacilli. Minimum, it will contain 10 power 4 bacilli. And whenever this is expelled out, there is a cavity, and this cavity is having 10 power 9 bacilli. So, which is the most infectious lesion of a tuberculosis? Most infectious lesion of tuberculosis. It is going to be cavity. Okay, the cavity contains 10 power 9 organisms and is the most infectious lesion in tuberculosis. Whether cavity will occur in primary tuberculosis? No cavity. Okay, cavity will be seen only in patients with secondary tuberculosis. Secondary tuberculosis, very, very important thing. Okay, so how this primary TB can present? Okay, primary TB can present. Okay, this primary TB can present in the lung first as cavity. Okay, this cavity can be filled with caseous material which is expelled out, and now this is replaced by aspergillus. What is this called as? What is this called as? I'm not putting as KCl. I will put it, okay. I will put it as green color. Aspergilloma. Okay. Or else I'll put it as black color. Aspergilloma. Okay. Aspergilloma. Okay. And what will happen? The surrounding area will go for destruction. So there can be fibrosis. The patient can present with fibrosis. Okay. Fibrosis. Okay. Then this material can enter into the, just for understanding I'm putting here, can enter into the airway. Okay. Airway. Yellow illapa. I'm putting black. See, I have put already black here. Okay, black. So now you tell me, what is this? Aspergillus, aspergilloma. We have discussed already, right? Aspergilloma. It can enter into the larynx as laryngitis. Okay, laryngitis. It can distract the airway and can result in bronchiectasis. Bronchiectasis. Okay, it can form lot of sedimentations in the bronchus and it is called as broncolithiasis. Broncolithiasis. Okay, sometimes this caseous material can rupture into the vessel. Okay, and whenever you have bleeding, that is caseous material. This is caseous material. Okay, now whenever you have a patient with tuberculosis, usually the bleeding will be from the bronchial artery. So bronchial artery is the reason for hemoptysis in patients with, whenever secretions gets dried up, what will happen? Whenever secretions get dried up, they can develop bronchiolithiasis, right? Yeah. Okay. Bronchial artery. Okay. This is the source of hemoptysis. But whenever it ruptures into the pulmonary vessel, what will happen? Where the bleeding will come from? The bleeding is going to come from the pulmonary artery. Okay, whenever this caseous material will rupture into the pulmonary vessel, the bleeding is going to come from pulmonary vessel. And what is this called as? Usually the bleeding will be from bronchial artery, but now the caseal material ruptures into the pulmonary artery. What is this called as? This is called as Rasmussen aneurysm. Okay, Rasmussen aneurysm. Then what happens? This can cause reactive pleural effusion. It can be reactive pleural effusion, right? Pleural effusion, and this can get infected and result in empyema. Can be filled with air, pneumothorax. So these are the complications of your tuberculosis. Okay, complication of tuberculosis. Okay, so these are the features you get to see in patients with tuberculosis, and this is going to be the complication arising out of tuberculosis. Okay, so with this we are finishing the initial part of tuberculosis. Okay, now what we will do is we will go for a lunch break. After lunch break, we will start again with the other manifestations of tuberculosis. So 40 minutes, okay for you? 40 minutes? 40 minutes. Yeah, all complications are seen in secondary tuberculosis. Secondary TB. TB only will cause. Pulmonary bronchial artery is more commonly involved. When pulmonary artery is involved, what is called as? Then it is called as? It is a reactive feature of tuberculosis. Pleural effusion is a reactive feature of tuberculosis. I already told in the class, I think. So it is a hypersensitive reaction to TB bacilli. Okay. So we'll go for lunch 40 minutes from now. Okay. Then we'll start. Which first page? First lung. What is here to lung experiment? See, there is a cavity. Cavity will be filled with aspergillus, aspergilloma. Surrounding area may go for fibrosis. Patient can have bronchiectasis, broncholithiasis. These are multiple presentation of your tuberculosis. Which one you want? This one. This one. Yes, this one. Huh? This is TB. Okay. See, the most common site of secondary tuberculosis is apical tuberculosis, which is going to be due to increase in the oxygen tension. Okay. And the lesion which is above the clavicle seen is called as pulse lesion. The lesion which is seen below the clavicle is called as Asman focus. Okay. And Simon focus, whenever an old TB patient has an apical scarring, okay, with a fibronodular patch there, okay, it is called as Simon focus. Okay. And whenever you have a TB where the primary lesion in the body itself, okay, is going to be involving the meninges, then it is called as rich focus. Okay. And if you see here, your TB bacilli is contained inside the granuloma, okay, in the caseous material. Whenever there is something which ruptures that granuloma, what will happen? The caseous material will be driven out and there will be a cavity formation, and that is called as cavity. Okay. Cavity is the most infectious lesion. Yes. See, it can lead to see, everything will not occur in every patient, right? Okay. So it will only when it ruptures the vessel. Okay. When it see, this is a alveoli. Okay. So if I'm going to tell you in Tamil, இங்க ஒரு ஆப்சஸ் இருந்தா மட்டும்தான் ரப்சர் ஆகி இங்க போகும். இங்க கம்யூனிகேஷன் இருந்தா மட்டும்தான் பேஷண்ட்டுக்கு வாமிட் வித் பிளட் வரும், ஸ்பியூட்டம் வித் பிளட் வரும். ஓகே. இதே பேஷண்ட்டுக்கு இங்க இருக்கு, இந்த சைட்ல இருக்கு, அப்ப என்ன ஆகும்? whether it will touch the pulmonary artery? No, right? So it depends upon the position. It depends upon the position. So it can spread through blood. Okay. And if it spreads through the blood and involves all the regions of your lung, then it is going to be your miliary tuberculosis, and the size of the nodule should be less than 3 millimeter. Okay. Choroid tubercle ஐக்கு போற சின்ன சின்ன வெசல்ஸ் வந்து அப்ஸ்ட்ரக்ட் பண்ணிடுது அந்த டிபி பேஸ்ல. அப்ப என்ன ஆகும்? அங்கெல்லாம் வந்து you will get lot of areas of haziness. That is called as choroid tubercle. Rankis complex is a calcified, okay, calcified primary complex. Calcified gons. Pulse is an apical tuberculosis above the level of clavicle is called as pulse lesion. It's an apical tuberculosis above the level of clavicle. Simon is, so you see here what I have written, apical scarring. Whenever it is scarred with a fibronodular patch, then it is called a Simon focus. See, everything will not occur in every patient, right? These are different findings you get to see. You might get, you may not get. எல்லா பேஷண்ட்டுக்கு எல்லாமே present ஆகாது இல்லையா? These are few things which can be seen in few patients. Asthma is infraclavicular, I told you, right? This is clavicle. Okay, this is clavicle. Above clavicle, pulse lesion. Below clavicle, Asman focus. Pulse Asman ஒரே மாதிரி focus. It's an active focus. Whereas Simon focus is apical scarring with fibrinodular patch. It's a scarred focus. Understood? Okay? Yes. Okay, I will show you picture here. How this looks. This is calcified. What is this called as then? Whenever it is calcified, what is this one? You see calcified. The subpleural focus is classified. Calcified. What is this called as? Rank is complex. Okay, rank is complex. Okay, so pulse lesion. What is this one? What is this one? What is this one? This is pulse lesion. See, choroid, I will show you the picture. Choroid tubercle is one which is going to be so this is because the vessels get occluded in that area, local areas of patchy involvement is called as choroid tubercles are called as this one, choroid tubercles. Whenever this vessel gets occluded with the bacilli due to dissemination, you get to see lot of areas of haziness in the eye. These are called as choroid tubercles. It will spread through blood. It will spread through blood or through alveoli, through the small bronchioles. Anything it can happen. Any kind of spread can happen. Hematogenous or lung or different organs pochina, then it is going to be blockage of retinal vessels. Okay, understood?